Hi, my name is Dr. Steve Auerbach, and I'll be presenting today an overview of what is expanded and improved Medicare for all, more properly perhaps known as single payer or explained as national health insurance. I like to refer to it also as the All America Plan. As a career U.S. federal officer in the U.S. Public Health Service, I consider myself a patriot, hence the red, white, and blue theme you'll see in a lot of these slides. And I would like to argue that this would be the best plan, both morally, ethically, medically, and economically, for everybody in America, hence the All America Plan. I have no financial or relationships or any commercial interests in anything I'm discussing. I am an activist. I'm a member of the board of directors and the executive committee of Physicians for National Health Program, New York Metro chapter. We are a not-for-profit educational and issue advocacy organization. I receive no financial compensation. In fact, participating with them costs me money, since of course I'm supposed to fundraise. Um, so, some background on the U.S. healthcare system. First, let's go way back to first principles. What is the purpose of insurance in general and health insurance in particular? So, the underlying point of insurance is to spread the risk. We refer to the insurance pool, that's the everybody paying in certain amounts on a regular basis. Everybody who's covered pays in a certain amount every month. Um, and the reason to have an insurance pool is it's always too expensive for any one individual to pay the full price at any single point in time. Way back when Lloyd's of London was founded to cover colonial ships going out to trade goods internationally, the cost of a ship sinking was too expensive. So everybody paid in for the ship insurance, the same as you pay in for your car insurance, your malpractice insurance, and health insurance. So if everybody is paying in all the time, then for any given event at any for any one person at any single point in time, it then pays out. So that's the point of an insurance pool. And hence you can see right away that the most natural and efficient pool for everyone in the US is everybody in the US. Hence the slogan, everybody in and nobody out, actually gets to an important policy and economic point of the purpose of an insurance pool. Now let's contrast that for a moment with what is the actual business of for-profit private corporate health insurance. Well, their actual business is to create an investment pool for Wall Street. Actually paying healthcare is their loss leader, what they actually call the medical loss ratio. And hence, they actually only compete by selecting for covering only part of the overall pool, that part which is less sick, less costly, in other words, the healthy and the wealthy. And they have every incentive, and they only compete by, in fact, dumping the sicker back into either the uninsured or the public pool, hence making the latter more expensive. So, how did we get here? Well, the massive growth in nationwide private for-profit health insurance started with the wage and price freeze imposed by FDR during World War II, right after unions had begun to have their massive expansion coming out of the New Deal. And so, unable to negotiate for wages, they negotiated for benefits instead. And this generated the creation and expansion of employer-based private group health insurance, and especially back when unions were more powerful and more widespread as part of union negotiations. So who isn't covered when you have that? Well, the elderly, the retired, the chronically disabled not in the workforce. And so we brought in Medicare in the early 1960s. And then also those persons who were very poor with children, so-called quote unquote deserving poor, and that's where Medicaid was brought in. Um, With the Affordable Care Act under President Obama in the late 2000s, we had an expansion of this to cover folks who weren't otherwise covered in the existing system at that time. And the ACA did do many good things. And the one thing it did was it created insurance, private group health insurance pools and programs that folks could buy if they didn't belong to one otherwise. So if you were not lucky enough to be able to buy into private group health insurance through your employer, which many folks are not, um, then just by the fact that you were in the state of, let's say, New York, well, if you had no other private group health insurance, you could buy group health insurance on the New York exchange, the New York marketplace. And then it also expanded Medicaid greatly, both by systematizing nationwide the percent of federal poverty level at which people were eligible, and also doing away with most of the other requirements, such as having dependent children. And so, in fact, Medicaid actually became, for the first time, a more universal program for very poor people, rather than poor people who also met other criteria. Um, it put in some other benefits and changes, ostensibly creating access to care by guarantee issue. In other words, no pre-existing condition exclusions. That guarantee issue, of course, only works if there is also at the same time community rating, which means roughly the same premiums regardless of your health status. It's no good having guaranteed issue. Oh, sure, we'll cover you even though you have cancer and asthma and chronic heart disease, but we'll sell it to you, but the premium will be $10,000 a month. So that doesn't really work very well. So hence, guarantee issue and community rating together, along with some degree of modifying lifetime caps, including under family coverage up to age 26, a certain standardization of essential benefits, not well defined, um, and at least trying to rein in the degree that which the insurers can make their profits, limiting medical loss ratio ostensibly to 80 to 85%, albeit with a fair amount of cheating, depending on what they sort of tuck in their accounting into administrative costs or profit making or healthcare. Um, and so that's where we are with the Affordable Care Act, constantly being attacked by conservatives. This is not we're not endorsing any particular party, but it's clear that one side wants to cut the Affordable Care Act, cut Medicare and Medicaid, keeps increasing the degree of privatization, often with public money even further subsidizing for-profit companies. Remembering that the ACA premium support is in effect taking public money to help people buy the private for-profit health insurance product, a good thing for them, but it's doing so by taking public money and essentially using it to guarantee the profitability for Aetna or United or whoever is selling on the ACA exchange. Um, and the other thing that's pushed by one side is ever lower cost, quote unquote, plans. That is to say, plans with very low premiums on a monthly ongoing cost, but in return have very high deductibles and high copays and narrow networks. So they're low cost until you actually get sick and need it, at which point it makes healthcare unaffordable. As we've moved forward since the ACA, what we've seen from the conservatives on one side is also the idea of, well, let's tinker with some incremental changes, but leave in place the existing fragmented, complex Rube Goldberg of a system, which continues to leave in a multiplicity of private for-profit insurance companies with the backstop of some degree of the public systems, Medicare and Medicaid. But we've also seen a increasing ever since 2016 progress with single payer going more and more mainstream, a reinvigorated single payer movement. So first of all, let's define our terms. What is single payer? Single payer is publicly funded, that's the national health insurance, publicly funded, private delivered single payer national health insurance. Publicly funded, replacing what is a de facto regressive or flat tax of premiums, copays, and deductibles and out of pocket costs, with everything covered by a single progressive tax. Privately delivered, it is not a national health service, it is national health insurance, national health funding. So the current system of independent private doctors and hospitals stays the same. All the providers, all the doctors and hospitals and other providers would take the same insurance, and everybody would have the same insurance. So at the federal level, this is the bill by Senator Bernie Sanders, S 1129, and House Member Jayapal is the lead in the House, HR 1384. Those were the bill names in 2019, 2020. And in New York State, we have a state level single payer bill, the so-called New York Health Act, which is in the Assembly and the Senate in New York. Now, very important, and one of the reasons I don't like the term Medicare for all is that what is being proposed in all of this legislation is not simply Medicare as it currently is, but just expanded to age 0. It is not just that. It is, in fact, massively expanded, improved benefits. It's more comprehensive benefits covering all medical, dental, mental, dental, hearing, vision, drugs, devices, and long-term care. It is different in that it's paid for by progressive taxes rather than premiums, and hence the net effect is that it is less expensive for 95% of people. That is to say, in effect, it's actually an increase in the income for 95% of people, plus they get the security of always having coverage, and the freedom of choice increases because all the hospitals and doctors and healthcare providers and pharmacies take it, so there's no more narrow networks. It's greater freedom of choice for patients, greater security. You simply have it forever, regardless of any changes in your employment or other life circumstances. And for 95% of people, it amounts to an increase in their income. The economic argument for it is that, as we've seen in the previous slide, the incentives for private for-profit health insurance are inherently perverse. They inherently only earn money by avoiding to cover sick people, fragmenting the insurance pool, paying for the least possible care. It can't be fixed. That's their inherent fiduciary responsibility and incentive. The only way to cover everybody, reduce total systems costs, and reduce the cost to individuals, families, and also those businesses and employers that are current participants in the system is single payer. And then again, the moral argument. Do we consider access to health care a private for-profit commodity to be purchased? In other words, some other widget du jour like your cell phone or some tchotchke you want? Or is it a social need and a communal good? We often make the comparison to the fire department, where everybody, you're paying in for your local fire department as part of your regular taxes, hopefully more progressive. The fire department is always just there. And God forbid you have a fire, the fire department comes and they put out the fire. When they arrive, they don't ask you for some additional money up front. They don't wait until 20% of your house is already burned down, and they don't ask you for additional money. In other words, there's no copays, there's no premiums, there's no deductibles. So the rest of the talk will explain and support all of these statements that I've just made, including with peer review academic literature cited. So first of all, one of our problems is there are still, despite the ACA, remaining uninsured. At the time of the ACA, there were over 50 million uninsured. With the ACA, we've cut that roughly in half. And after the election in 2016, with the new Republican president, Senate, and Congress in 2017, a lot of us thought that it was immoral to just take away the Affordable Care Act and throw 25 million people back into uninsured. But we would also argue that it is not okay to still be leaving 25 million people still uninsured as they are. So who are the remaining uninsured? Well, this is prior to the COVID pandemic and the recent fall in the employment rates nationwide and the great loss of health insurance that's gone with that, which of course further points out the problem of having employer dependent health insurance, which makes no sense whatsoever. But prior to that, at the best, around 2018, the Urban Institute, not a fan of single payer, um, it came out and did an analysis showing that one of the key things in the remaining uninsured is that it, in fact, is not mostly people who are here undocumented. In fact, the majority nationwide of persons who are remaining uninsured, in fact, are people who are eligible for the subsidies available to them in the ACA, but are not enrolled. The system is just so complex. There's so many hoops to jump through. Um, they're eligible for subsidies. They're still not enrolled either because the system's too complicated, or they're on and off in the churn between insurance, or they feel even though it's eligible for subsidies, they've still chosen not to be insured because of it being too expensive. Another 25% are eligible for Medicaid, but not enrolled in Medicaid. Again, too many complex hoops to jump through rather than having it just be automatic. Too much paperwork, too many obstacles to getting enrolled, even though they are eligible in their given state. An additional 15% are not eligible for subsidies because their income is too high, but they've still chosen not to buy into the ACA insurance. Additional 9% are ineligible for subsidies due to the offer of potentially being eligible for employer coverage, but are not actually in their employer coverage. And finally, yes, about 16% are ineligible for assistance because of their immigration status. So just 16% nationwide are in that category. And an additional 9% would be eligible for Medicaid, but their particular state is one of those states that did not adopt the Medicaid expansion. So we see actually that the vast number of folks who remained uninsured despite the ACA are because of the same broken factors, regardless of the ACA, in having the fragmented private insurance system and even public insurance having so many hoops to jump through rather than just automatic eligibility, which is so much administratively simpler. But I would argue that focusing a lot on the completely uninsured misses the bigger problem of actual having underinsurance. And for those who are insured, it's still too damn expensive. We see here the rise in the costs in yellow and orange of how much people have to pay for premiums, rising much faster than raises the rise we see here in the blue and black in overall inflation rate and workers' earnings. We see here, again, the much more rapid rise in deductibles, even after you've paid your premium, the deductibles going up much faster even than the premiums, which themselves are going up, as we saw, at twice the rate of overall inflation and earnings. We see here the fact that underinsurance, using a standardized definition from the Commonwealth Fund, has continued to increase despite the Affordable Care Act, more than doubling between 2003 and 2016. We also know that just having insurance doesn't by itself guarantee you access to care if, especially for example, if the doctor or hospital don't take Medicaid, which nationwide many don't. Now, as a pediatrician, I am proud to say that general pediatricians, close to 3 out of 4 general pediatricians do take Medicaid nationwide. However, in the pediatric subspecialists, many do not. And as we see here, a majority of such physician specialists do take appointments for children nationwide if they have private insurance, but the numbers are a fraction of that, around a third of those that then take public insurance, notably Medicaid. We know that healthcare costs continue to be the leading cause of personal bankruptcy. 2 out of 3 persons filing for personal bankruptcy attributed Healthcare costs is the major factor, either directly from the medical bills, or they got sick, therefore lost their work, therefore lost their insurance. Again, the problem with having health insurance based on employment. Of those who filed for bankruptcy, over 3 out of 4 had actually had health insurance when they became ill, and they still went medically bankrupt. So having health insurance nominally does not prevent you from going bankrupt when you get sick. 57% of persons who lost their homes due to foreclosure during the Great Recession that started around 2007 identified medical debt as a major cause of the home foreclosure. Again, medical debt being the number one stressor on people's ability to pay all their other bills. Medical bills are the most common reason for collection agency calls, 59%. All other causes combined, telephone, utilities, legal and court, back due on your rent or taxes, were only 41%. And it was the only category not to vary by income. So it's not just the very poor, it's also the middle class. And of course, medical bills are infamously the most common reason for personal GoFundMe campaigns. So again, underinsurance, the fact that private health insurance is kind of like a hospital gown, even though you have it, the chances are your ass isn't covered. Again, copays, deductibles, out of network, unreimbursed costs so high, premiums going up, 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 the copays and deductibles going up, up, up. And that trade-off of higher versus lower premiums up front for higher costs with the copays and the deductibles and out of network costs if you do get sick. And then so many who do nominally are sick, nominally have insurance, but when they do get sick, still go bankrupt. I would be remiss as a former employee of the Health Resources and Service Administration, not to mention the maldistribution of healthcare providers geographically. The federal government actually engages along with state partners in health professional shortage area designation. And basically what we see here is a combination of how many providers are there per population, as well as travel time, as well as the wait time, how long it takes to get an appointment, balancing out. And you can see that there are many areas, let's say in New York, that have too few providers, in this case, too few primary care providers per population, taking into account both the number of providers and travel time. Basically, this is a problem, as you would imagine, in inner city poor neighborhoods as well as in rural areas. Now, private insurance is inherently less efficient than the public insurance. It's got greater administrative waste, overhead, and just outright profiteering. As we saw before, private insurance costs are actually rising faster than public insurance costs. We saw that before with the premiums and deductibles rising so much faster than baseline inflation rates or income growth. Here we see the fact that private health insurance costs are rising much faster than Medicare or Medicaid over time, and that in fact, whatever reforms the ACA did nothing to control that, with the ACA having come in around 2011. Big savings from single payer. The administrative and profit overhead of the private health insurance companies, as you can see here, runs between 15 and 18% compared to Medicare at 2%. So the difference between that 2% and the 15% is basically money not going to healthcare, but going into the pockets of Aetna and Humana and United and WellPoint, etc. Insurance overhead as measured per capita is far higher in the United States than it is in other Western developed capitalist democracies. Comparing the United States here to Canada, Holland, Germany, Switzerland, and France, we can see that the overhead of administering the insurance side is roughly 5 times greater. One of the things we've seen in the United States, one of those only in America phenomenon, is the fantastically enormous large growth of healthcare managers compared to physicians. Well, the growth in the number of physicians has gone up by very little, as you can see in the yellow on this graph. They're being managed by more and more and more health managers over time, with a much more rapid growth of all of that administrative bureaucracy and overhead. It's gotten to the point now where Duke Medical Center, which is 3 hospitals in the greater Durham area of North Carolina, academic university medical center, 3 hospitals, 957 beds, has 1,600 billing clerks for 957 beds. That's insane. Duke's cost to send bills for one primary care provider is $99,000 annually. That's their cost to do the billing to the doctors. Cleveland Clinic has to maintain 210 million different prices in their computer system. Again, this compounded complexity for a hospital medical center that takes patients from all over the country, that they have 3,000 different contracted rate schedules multiplied by 70,000 codings, turning into over 210 million different prices. This, again, is just completely insane. Hospital billing and administrative costs. So before we were talking principally about the insurance overhead, that difference between the 15% of private insurance and the 2% of Medicare. But on the delivery side of care, there is the added costs of billing and administration when you have this multi-payer system and denial of care and having to file each claim multiple times, etc. Comparing on the hospital side, compared to Canada and the US, we see again roughly about 5 times the cost for hospitals, let's say Massachusetts General or Duke Medical Center compared to the University of Toronto or University of Vancouver, University of British Columbia Medical Centers. Again, academic tertiary medical care facilities compared to each other, 5 times the cost. For a physician office, again, even more than 5 times the cost. When you're out there as a solo physician, billing, and you take insurance, which nationwide, despite carriage trade practices in New York, nationwide most doctors have to take insurance. You wind up having all these different managed care companies to deal with. And in Canada, you have one. So overall, again, administrative cost per capita on the on the delivery side, roughly 4 times the cost than Canada. We pay more on a unit cost for our drugs and devices. Per capita spending on prescription drugs in the United States is higher than it is in other countries. We pay anywhere between 1.5 to 4 times the price for any given drug. And let's remember that these are all transnational pharmaceutical companies. Really the same drugs from the same companies, often from the same factories. But because the other countries negotiate the prices nationwide, and we, thanks to corporate lobbying of our politicians, are in most cases not allowed to negotiate the prices down, except for the VA, Veterans Administration, DOD, and certain aspects under certain parts under Medicaid, are not allowed to negotiate the prices, or the insurance companies are in a twisted, complex relationship with the drug companies, and certainly don't have what we would call monopoly power, the power of one buyer to be able to negotiate prices that there would be with single payer. We're paying 1.5 to 4 times the price. Remembering again that these are the same transnational companies, their reasoning about oh, we're doing it for the research, we need the money for the research, is not true in multiple ways. First of all, it's just not true. Only 13% is actually going to what they consider research and development, a relatively broad term. In fact, most of it's marketing, administration, manufacturing, and 18% for after-tax profits and 7% taxes. That's their cost structure. And of course, primary research is mostly done on the public dollar, NIH and National Science Foundation, publicly funding primary research, which by a law passed in the late 70s and early 80s, the so-called Bayh-Dole Act, the NIH, the public, is actually not allowed by law to participate in profit sharing on the patents that are derived from publicly funded research. Now, we're not asking the drug companies to not make a profit. We're just suggesting that they should be able to make the same profit, the same return on revenue as other Fortune 500 companies. What you see here is that year in and year out, drug companies make roughly 3 times the profit return on revenue as the Fortune 500 median. Basically, the difference, at least one part of this difference, why they make this excessive profit compared to even other Fortune 500 companies, is the fact that while those other Western developed countries, France, Germany, Sweden, Australia, Taiwan, etc., are all negotiating lower prices, essentially they're making their excess profits on us here in the US, costing us a lot of money. It's similar with devices as it is with drugs. This shows paying higher unit costs for a series of regular devices, mostly in the surgical area, but also single chamber and dual chamber pacemakers and stents, for example. Similarly, for an orthopedic implant, again, manufacturing, sales, and administration are the biggest costs. Research and development is actually a very tiny percentage. So overall, what we see here is higher drug prices compared to other countries, higher prices per procedure per lab test, higher and growing costs of administrative costs, and out of control compared to background inflation and wages. So it doesn't have to be this way. And I'm going to make now, by contrast, the case for single payer. Every other country covers all of their residents and spends on average half of what we do, many with no cost sharing whatsoever. We see here the growth in GDP going back to 1980, where the United States was already higher than most of the other countries in the Western developed world, but the percentage of GDP accelerating more and more fast and diverging from the other lines of the other countries. So we are unable to control our costs in our current system, inherently less efficient because of private insurance. 2/3 of our spending is already coming from our taxes. That's one of the saddest parts of all of this. We already see that a certain percentage is Medicare and Medicaid, but in addition, there's the tax subsidies that are going to support things like the amount you can deduct from the taxes you pay for your premiums, as well as the amount of money that's going from taxes to support the ACA premiums. There's the fact that government workers have as a benefit, as a worker, a benefit of the state, federal, city, county paying part of their premiums. And of course, there's the VA and various other public sectors. Pure private is already down to 35% of the total. So what we see here is, in terms of total spending per capita, we're already spending more than other Western developed countries. We already pay the same amount in our public, and additionally an amount in our additional private, as shown in the red, but we're not getting the bang for the buck. We still have so much uninsured and underinsured and too expensive to get care and can't access the care. So, nice natural experiment here. The United States and Canada both completed implementation of some changes in their healthcare system in the early, around 1972, 73. So Canada began implementing on a province by province basis in the early 60s their form of provincial based single payer. And here in the United States, we passed something called the HMO Act under Richard Nixon, which, despite the name, actually was the beginning of an acceleration of privatized for-profit including investor-owned, Wall Street-owned insurance. And so what happened? Well, they went to universal public and were able to control total costs. And we went to an ever more privatized for-profit system, and our costs accelerated and took off even worse, with the lines diverging. It certainly is not a case of our getting a better outcome. In fact, we have a progressively worse outcome compared to Canada, where there had been a 1 year difference in life expectancy, and it has now gone up to 3 years. So overall, it's not better outcomes comparing the United States to Canada, but also other Western developed capitalist countries, but those that have universal health care, which all of them do. Our life expectancy is worse in those other countries. It's not better maternal mortality. This is certainly a tragedy in the United States, where it has continued to decline in all other countries, and yet has taken off and accelerated and actually gotten worse in the United States. It's not rationing. We'll come back to that later. But other countries actually provide as much or more care than we do. Other countries provide more inpatient days per capita than we do. Not rationing. Other countries provide more outpatient physician visits per capita than we do. It's not rationing in those other countries. They provide more long-term care than we do. A huge and growing expense with the aging of the population. In fact, it is in the United States that more patients skip or delay care, or essentially self-rationing their care, not because they don't need it, but because they can't afford it. Other countries have more elderly, so they have more elderly and more sick, and a higher percentage of their population needing care than we do, based on age, and they also have more smoking than we do, for the most part. We do, I will admit, have more obesity. Now, international comparisons. So again, this was done by the Institute of Medicine and using so-called OECD data. And if you compare the United States on a variety of measures, and where do we rank compared to 17 peer countries? So among 17 peer countries, from ages 0 to age 60s, basically, what we see here is that the United States ranks at the bottom. So we're either 17th or in some cases 16th out of all countries, peer countries. And that's, again, Australia, Austria, Canada, Denmark, Finland, Germany, France, Greece, Japan, also Italy and Norway. So we rank last amongst those peer countries until you get to our equivalent of more or less single-payer universal public coverage with Medicare. And when Medicare kicks in the United States, we not only become more equivalent to the other countries, but all of a sudden, on a whole bunch of these composite measures done by the government's own Institute of Medicine, all of a sudden we start doing quite well. So the U.S. care system is able, when it has Medicare, to do quite well. And so we should have an expanded and improved Medicare for all. So excess deaths due to uninsured and underinsured, there's a whole variety of studies using different methodologies. Basically, it comes down to somewhere in the range of a minimum of 18,000 excess deaths per year and as many as 68,000 excess deaths per year. And the references are here. So this is due to basically not having to pay out of pocket, uninsured or underinsured. Single payer makes economic sense. The folks who will say, oh, it's too expensive, basically don't understand healthcare economics. There have been numerous studies done over the last 20 plus years, all of which show savings, some greater, some lesser savings. Review articles are cited here, but on average, roughly 5.7% savings in total spending on health system-wide, with the added advantage of everybody's actually covered and doesn't have out-of-pocket costs blocking their access to care. And there's been endorsements by many economists that now is the time for Medicare for all expanded and improved national health insurance. So how does the econometric analysis work out? This is just one example, but it's a slide that shows kind of where the different slices of increase and decrease costs are when you shift from our current system to universal health insurance. So this is actually the RAND study, a center-right group that was brought in to do the analysis for the New York Health Act, New York State's own single-payer proposal. And what we see here is, as I was describing before, there's reduced costs on the far left there in red, the minus 20.4 billion. There's reduced costs due to the reduced insurance administrative overhead. There's reduced costs due to the reduced costs on the delivery, the hospital and doctor side. And there's the reduced cost because of savings of negotiating prices and devices downwards for a net savings of 17.7%. And there's an increased cost because now we're covering everybody and we're eliminating the cost sharing, no more deductibles or copays, and that's a 5.5% increase. There's actually an improvement overall in provider fees, especially for primary care physicians across the board. And we are also now going to cover long-term care under any of these plans, whether it's the New York Health Act or the current versions of national single payer, and that costs money. And in net, the RAND Corporation's analysis shows a net savings, even with the addition of long-term care, even with no copays and deductibles, even with the expansion of coverage to everybody and for all medical and dental and mental health and drugs and etc., a net savings to total systems cost. This is analysis that was done by a center-left group at the University of Massachusetts, Professor Pollan and others, showing for the Sanders bill at the national level that new expenses with basically more health care provided would have an increase in costs of 12%, but there would be the savings, the total system administration side, that's both the savings on the insurance side and on the delivery side from just going to a single payer, as well as the drug pricing, uniform rates, and as always, a little fraud and waste thrown in there, savings, showing again a net savings of, in this case, about 6.7%. So what happens if we compare our current system to either a public option or single payer? Well, the basic problem with public option is that it increases your costs because you are covering more people on the public side, or you're covering more people by giving the insurance company extra money to cover them, but you're not getting the savings. You're still leaving in place the fragmented for-profit system. And so if you go to our current system of 2.4 trillion, you could increase, but still not cover everybody and pay 3.63 million, or you could actually cover everybody and pay 2.93 million. So again, actually single payer is the option that makes the most economic sense. We do need to bear in mind the issue that those administrative savings are, to a great extent, not only, but are in part people losing their jobs. And therefore, we have to have a just transition as we go through this process. So the savings on the health insurance side basically means eliminating most private sector health insurance jobs. That's estimated at about 800,000 jobs currently, at an average wage of about $70,000. And the savings on the health services delivery side, getting rid of all of those excess clerks pushing paper to deal with the multi-payer for-profit private insurance billing, Basically, it's estimated that we would be getting rid of about 65% of those workers. That's about 1 million people earning on average about $40,000 each. Fortunately, we're progressives. We actually care about workers. And in fact, the single payer bills call for a so-called just transition with at least 1% of what is now the much larger government health budget expenditure of up to 5 years being devoted for those displaced workers. It turns out that when you run the numbers, that's enough to provide complete wage replacement for all of the displaced workers under the age of 65 until they reach under the age of 60, from 60 to 65, as well as 1 year of complete wage replacement for all the workers displaced under the age of 60, plus job training and relocation support for them. Needless to say, that's more than what folks get in the current system when they are become unemployed. And it should be mentioned that in our current system, 1.8 million is a small amount of the national total churn in jobs. One of the key factors for why I support single payer, and you should too, and why it's so much better, is that it's progressively paid for. So the current system, as I had mentioned before, essentially, it's the same premium for any given plan, regardless of your income. So for the same coverage, whether you are Bill Gates or a resident physician, or maybe one of your patients, if you're a trainee in a poor neighborhood, or somebody who's just flat out broke, the premiums that you pay are the same, which essentially is a flat or regressive tax. If you get sick, and obviously the non-rich get sick more than the rich do, then you're also paying your deductibles and copays and out-of-network and out-of-pocket expenses. And of course, it's even worse because if you are middle class or poor, you may well have bought a higher deductible copay plan to save money on the premiums, but when you get sick, your costs are even higher. Compared to that, single payer is going to be paid for by progressive taxation. At the very least, the same progressive income tax that we have currently, and hopefully a more progressive tax. An analysis recently done by the economist Naomi Zood at the CUNY School of Public Health shows that currently, under our current status quo, lower income people who are above the Medicaid, so they're paying for premiums, lower income people are paying the 8 to 9% range of their income to healthcare. That would only be a little bit reduced under a public option system to 6 or 7%. By comparison, the most wealthy are paying only 2% of their income currently to healthcare. Whereas under a single payer system, the lower income folks would be paying 1 to 2% of their income, and the wealthy would be paying as much as 4.5 or 5.5% of their income to fund the healthcare system. Another way to look at this is that for those in the lower 95% of people, they would actually be paying less and hence would actually have a net increase in their income by as much as 18% net increase in income, plus guaranteed health insurance, better coverage than they have, and the security that it's always there. And only the top 5%, roughly those above $460,000 household incomes, would be paying more. An example of how this works in actual dollar amounts for the New York Health Act is that the premium for somebody at an income of $50,000, roughly the median, would be paying a monthly premium of $188 per month. Persons of low income under $25,000 not paying anything. Persons at $100,000 paying around $666 per month, and those at $400,000 paying $4,500. So we see here that it's a higher percentage of their income as their income goes up. What are you getting for that? Well, you're getting everything. again, current Medicare as it is actually doesn't cover everything and requires out-of-pocket costs either for so-called Medigap coverage, as well as premiums for Part B and Part D, and the various deductibles and copays, which on average are $6,100 for a current Medicare recipient, compared to none under either the New York Health Act or under the National Single Payer proposals. Again, for employers as well as households, if we treat premiums as the same as a tax, then in fact, the amount that it costs them is less under single payer, even if they are the employer, if they're an employer that's currently participating in the system and not a free rider. So the big lie is when they say it's too expensive. And the big truth is that it's total systems cost savings and cost shifting. So when they say it's too much, it's a false misdirection, because that's only looking at the federal government budget and saying, oh, look, the federal government budget's going up now that it's the single payer. Well, of course it is. It's the single payer. But what's going down is the total systems costs. It's going down in terms of the premiums, copays, and deductibles being paid by individuals, families, and households. It's actually lower costs for any of the businesses that are currently contributing to the system. In other words, those where you have that group health insurance through your employer and they're paying part of the premium as part of your benefits package. And in fact, an average savings of $9,000 per employer, for employers per employee on a 2013 calculation. And it's also lower cost to all lower levels of government. So for national single payer, it saves states, counties, and cities money. And for the New York Health Act, it would save cities and counties money. Why? Well, three reasons essentially. First of all, city governments are themselves employers. And so if the federal government is covering single payer, then state, city, and county employees don't have, as part of their benefits package, the government paying part of their premiums. It also covers local charity care because now everybody has insurance. And it also covers the Medicaid share, which in New York State is the largest part of the county real estate taxes are going to support Medicaid under the county state Medicaid share system. And in general for states, if you had national single payer, then the Medicaid share goes away for the states, which is under 50% under traditional Medicaid and much less, under 95% is paid by federal under the ACA expansion component. So bottom line, single payer saves total system money, actually raises income for about 95% of folks, replacing with progressive taxes, saves employers money if they're current contributors. It's actually good for all the companies other than the health insurance companies and pharma. And it provides the security of always having the coverage there and the greater freedom of being able to go to any doctor or hospital you want. So I would suggest we can't afford not to do single payer. Polling shows increasing support for single payer. This is polls by regular media outlets and standard commercial corporate polling organizations. This is not advocacy organizations. We see, in fact, amongst not only all voters, an increase in support, but we also see within all voters high rates for Democrats and independents, and even 50-50 among Republicans. So one of the arguments is, oh, if we do this, the system will implode if we let all these other people in and have access to care. That sort of points out the dishonesty of the argument that the system can't absorb the coverage, and if you bring in single payer, there will be rationing. As we've seen already, other countries, in fact, provide more care than we do. They're not rationing. And in fact, it is the current American system that is rationing. It's currently rationing by who can buy themselves access compared to everyone else who has either delayed care or no care if lower income or unable to pay. Other systems prioritize by medical need, and in the United States, we're prioritizing by ability to pay. Um, there are several recent studies that, in fact, look at what happens to utilization before and after healthcare coverage is expanded. Three very clever studies showing, first of all, if you compare what happened in all of those other countries, which, aside from Germany, mostly implemented forms of universal care after World War II. So roughly between 1946 and the 1970s, the other countries expanded to universal coverage, what happened in their utilization before and after, as well as what happened in the US before and after Medicaid in the early 60s, and what happened in the US before and after the ACA around 2011 when it was fully implemented. And what we see is there is indeed an increased use in the target population. Those who didn't previously have access did indeed start using healthcare a bit more. This was partially offset by a small decrease in utilization by others, which is felt when you look at the details of the analysis, in fact, to be a little bit decreased use and so-called overuse, which was often touted as a problem, that there's actually too much healthcare going on. So, but also there's an increase in efficiency, greater utilization of by the same resources. When you go from multi-payer to single payer, you've got your clinicians in your hospital spending less time dealing with insurance and coverage and payments and bureaucracy and administration, and they're spending more time on healthcare. And you can redistribute and have expansion of services where they are actually needed. And in a longer term, you may have reduced utilization per person due to improved health of the total population. And in fact, what we see here is not any particular surge in physician visits after the implementation of Medicare and Medicaid in the 60s compared to the 70s. And we see similarly not a lot change in physician visits after implementation of the ACA. And we don't, again, see in the United States a surge in care, a surge in hospitalizations per person after Medicare or after the ACA. It's all doable. There's also the claim out there regarding how somehow single payer is going to cause hospital closures. And again, this is false. Basically, the simple argument that's made is, well, currently private insurance pays more than current Medicare. So if you go to only Medicare, revenues will fall and therefore the hospitals will close. That's the argument. So it's false in a variety of ways. It's false because the case mix, simplified that way, is false because the real payer case mix isn't just private and in Medicare. It's actually, for real hospitals around the country, not just the elites, it's actually private plus Medicare plus Medicaid, plus they're having to cover the underinsured, uninsured, charity care, and no pay. Hospitals that are doing well under the current system are those that are not taking their fair share of Medicare and Medicaid already, and certainly not the underinsured, uninsured, and charity care. And those that are already taking their fair share or more than their fair share of Medicare, Medicaid, and the uninsured or underinsured, in fact, are the hospitals that are financially stressed. And in fact, it's in the United States that we have so many financially stressed hospitals and hospital closures. The Medicare reimbursement rate argument of, oh, Medicare is too low, therefore it's not enough and hospitals will close, is also false. First of all, there is no single Medicare rate. Hospitals that have actual legitimately higher costs currently get a higher Medicare rate reimbursement, and of course that would continue. So there's no single flat rate. We also know in the state of Maryland, and this used to be true in New York too, where they have what's called an all-payer system for the hospitals, it is already the case that private insurance is paying the hospital at the same rate as Medicare. And yet hospitals in Maryland are somehow or other managing to do just fine. The rest of the developed world manages to have their hospitals stay open and in fact are more stable and less financially stressed than the United States. So we know it can be done. And again, that false assumption of Medicare for all, meaning Medicare as it currently is, remembering that Medicare for all is a shorthand label, not the details. And in fact, the actual legislation doesn't call for specific rates. It calls for rates to be determined by a process similar to how current Medicare rates are determined, not that the actual rates being the same. And in fact, the most detailed proposal, which came from Senator Elizabeth Warren during the last campaign, suggests Medicare for all reimbursement rates under single payer would be about 110% of current Medicare rates, a little bit higher. And finally, the argument ignores the fact that there are savings for those hospitals, as we've already noted. They wouldn't be paying as much in overhead and billing and administrative costs. No more $500 bags of saline. They'd be paying less on drugs and on supplies. No more $500 bags of saline. And the estimates for those savings range from 10 to 25%. So again, it's under the current system that hospitals, in fact, are closing. They were closing before COVID, and they're even more threatened by COVID. Why is that? Well, hospitals are indeed dependent on their budgets being tied to individual case service reimbursement, which is crazy. The stronger versions of single payer, both the physician's proposal from PNHP as well as the Jayapal bill in the House, call for forms of global budgeting, making the entire reimbursement rate argument essentially moot. There's no good reason for patient care services to be tied for the budget or vice versa. We don't pay the fire station on the basis of how many fires they put out in a given year. We, in fact, have too many hospital beds, arguably, in some neighborhoods, in part because they're financed by private insurance, but also private donors and lobbying. And that can cause overuse. And we see the closures in poor urban areas and rural areas where needs are often greater, but the capital is scarce and reimbursement rates are too low currently. So in reality, it's the current system where hospitals are closing and supply is concentrated in other areas. It's under the current system where hospitals are dependent on elective case billing for their profitability, and finances are, as we've seen recently, threatened when the COVID-19 pandemic struck, and even more care is needed, but it's not profitable care. The elective, higher profit-making procedures go by the wayside because they're dealing with emergency rooms and hospital beds and ICUs filled with COVID patients. So right when need is greatest, the reimbursement system is actually causing, our current reimbursement system is actually causing more hospital financial problems. So again, it's the current system where hospitals close due to financial greed and are not located based on community need. Even the Mercatus Institute, funded by the Koch brothers, suggests that in fact payments to hospitals under single payer would in fact increase slightly, as the RAND Corporation and the Urban Institute, none of which are actually single payer supporters, and all of them, under their own analyses, show that payments to hospitals with and without single payer actually go up. Finally, why should you, as doctors, support single payer? What's in it for me as a physician? Well, first of all, same analyses by three groups that don't support single payer, the far right wing Koch brothers supported Mercatus Institute, the center right RAND Institute, and the center left Urban Institute, all agree that total payments to physicians would increase under single payer. We already know that in the United States, single physician satisfaction is very low. This survey has been done for many years with the Commonwealth Fund and the OECD. And physician satisfaction in the United States is always the lowest, other than Germany. I don't know what's going on in Germany. It's always the lowest amongst these countries and dropping. As a doctor, I hope you'd rather spend your time with your patients than doing other administrative tasks, including increasingly EHR and desk work. Only 26% of doctors' time is actually spent with patients, according to a recent study in Annals. This compares to direct patient care in Canada being 30 hours a week out of 40, and only 2.4 hours on administrative duties. This is a brilliant study showing the difference when you are using an electronic health record in the United States versus the other developed Western countries. So Epic is actually used in many countries across the world, but in the United States, it's used differently than it is in other countries. So electronic health records suggest that it's being used for health. So what we see here in red is the number of keystrokes, key punch strokes on your typewriter using Epic in the outpatient setting as published in Annals. The United States was 254 different organizations participating with 10 million different notes. And what we see here is the average characters key punched per ambulatory care note in the US compared to in those 13 other countries, there is not even any overlap in the average. 3 out of 4 of our charting, 75% of our charting, is for billing and insurance, not for clinical work. Other countries are using Epic to actually do health, and in the United States, our charting is for billing and insurance predominantly. US spend a lot of time managing insurers. The physicians are managing the managed care companies in the United States, spending almost $83,000 a year compared to $22,000 in Ontario. This is the cost of physician practice to interact with insurance. Overhead in the United States, 55% of overhead is devoted to administration, 28% is overhead in Canada, the rest being net income for those family physicians in Canada. Incomes are just fine, including for the specialists. So in Canada, family physicians are making on average $280,000, pretty much family medicine, internal medicine, peds, psych, OBGYN, all would see an increase in the United States. The hardest hit, sub interventionist, high specialties would probably take a 10% hit. Point is here, even the thoracic surgeons and ophthalmologists are doing just fine in Canada. Thank you very much. Medical practice in the United States is just tough. There's just too much burden and administrative overhead. There's many reasons individual private practice is dying, and most practitioners are becoming employees anyway in the United States under the current system. In fact, American physicians are moving to Canada. This is showing how many American physicians are practicing in Canada. This is showing the net migration is flipped. So net migration is no longer from Canada to the US. It's now from the US to Canada. Why? It's a bureaucratic mess and can't get anything done for patients here. In Canada, can focus on patients, not administration. There's been an increase in the support for single payer amongst physicians, now with greater numbers supporting it, gone from 42% to 56%, according to the Merritt Hawkins Corporation. They're a placement management company. And in peer review literature from Annals, did a study in 2003 showing 49% of physicians for single payer, and in 2008 that had grown to 59%. So roughly in those 5 years had gone up by 10%. So again, how's single payer going to impact physicians? Preserved earning potential, increased professional autonomy, increased career satisfaction, decreased administrative burdens. I'm for it. How about you? Well, it turns out that slowly but surely organized medicine is tipping in its support. So 2019, the AMA famously opposed a single payer going back to the 1920s. By the way, before that, they actually supported universal health care when it was first proposed by Teddy Roosevelt in the progressive era. And of course, we know the AMA represents only under 20% of American physicians are actually paid members. But in the June 2019 House of Delegates, we came close to overturning the opposition. It failed narrowly with 47% of AMA House of Delegates support. And the next largest group, the American College of Physicians, representing internal medicine, said either Medicare for all or a strong public option. And within that, the society representing primary care physician internal medicine more recently came out in full-fledged support for single payer being the way. We see here our broken, fragmented, kludge, Rube Goldberg of a system currently, and how single payer simplifies it and makes it better for everyone. So here's some linky goodness for you. I would encourage you all to join. If you're in the New York area, Physicians for National Health Program, New York Metro chapter, the link there is highlighted in the second line. And for those that want another further deep dive, there's a nice free download from Public Citizen making the case for Medicare for all with the link there provided. Thank you. There is a second part to this focusing on COVID and anti-racism and why single payer would be the dramatically improved health disparities, reduce health disparities, and would have caused much less problems with COVID. Thank you.